So then without further delay, we'll move on to the next session. It is on MDT approach, multidisciplinary team approach for spinal dysraphism. Sorry, I couldn't see the word because it was too small on the screen. The symposium would be chaired by Dr. Nirukshan Jayavira and Mr. Nuan Rodrigo.
Thank you very much. So without delaying, I think we should get on to the topic. So it's a multidisciplinary approach to the spinal dysraphism. So the introduction will be given by Professor Jitangi Wanigasinghe, consultant pediatric. Yeah, I would like to invite the panel members. Professor Jitangi Wanigasinghe, consultant pediatric neurologist. Dr. Vindhya Gunasekara, consultant pediatric nephrologist. Nirmal Marasinghe, consultant orthopedics and spine surgeon. Dr. Dimuthu Tennakon, consultant pediatric orthopedic surgeon. Dr. Jayatri Jagoda, consultant rheumatologist. Mr. Nuan Rodrigo, physiotherapist, Ledruge Hospital. Ms. V. Irosha Shamali, prosthetist and orthostist from SLFPO.
Okay, so very good afternoon. So let me start with this case. This is a 2-year-old boy who is from Kegol. He was born after unplanned pregnancy, so there was no preconceptional folic acid taken. But there was no apparent complication during the pregnancy. Pregnancy was detected at 12 weeks of POA, and it was only in the 3rd trimester that there was hydrocephalus detected. So that was the first sign of a problem. But in the ultrasound, there was no spinal deformity noticed. So the only risk factor that we could identify was maternal hypothyroidism. There was no history of diabetes mellitus, so the baby had an uneventful delivery. But the baby was transferred in utero to Castle Street Hospital, where there was access for all the care facilities. So at the time of birth, the baby was an active baby, of course, who was then for the first time identified to have this meningomyelocele, which was actually ruptured at that time. So the other findings were the baby had a relatively large head, but there was movement in both lower limbs. So probably at this point, maybe we can ask our co-chair, Dr. Nirukshan Jayavira, to tell us something about the early aspect of neurosurgical care and also the important things to do to preserve neurological function.
Thank you, Jitangi. So all these meningocele, spinal dysraphism patients, when they diagnosed, or most of the time when they after the birth, they used to refer to neurosurgical unit. So where all this management and multidisciplinary approach start from. So just let me recall your memories of this. What is this spinal dysraphism or spina bifida? So as you all know, there are two things, that's aperta, which is visible outside, and occulta, which is not visible but it's under the skin. So most of things are meningocele or meningomyelocele. As you know, it's meningocele, only the dural sacs are protruding and there are no neural elements inside. And the meningomyelocele, when there's a neural elements are protruded out, you call it meningomyelocele. And there are many names and very, it's a spectrum of conditions. But for introduction, I think you should remember this. And when it's occulta, and there are again a sort of a spectrum that it could be a dorsal dermal sinus or the pit, or sometimes lipomeningocele that are associated with the lipoma inside the dura associated with the spinal cord, or sometimes the diastometamylia, that means the duplication of the spinal cord, neuroenteric cyst, and sometimes just fatty thickened phylum terminale. There's a spectrum of disease actually. Shall we move on to the next slides? Yeah. So most important thing is when you see these conditions at birth, and these are the list of things. Sometimes they can have this the skin manifestations like skin stigmata, pigmented patch, or hairy skin. There could be a skin dimple or sacral pit, sacral sinus, meningocele, meningomyelocele. So all these are the spectrum, but you should know what you are going to do with the next. So the first picture just shows us the skin dimple. There's a just dimple in the skin, but most likely there won't be anything connected to the underneath the spinal cord. and the next one is I think it's a sinus. Oh, there's a small hole there. May or may not have a connection to the spinal cord, but sometimes may be attached to connection to the bones. And next one shows just a skin pigmentation. You don't have to do much about it. And then the one on the left has again the sinus, and the other one is just a hairy skin. No, these are all the skin manifestation. Obviously, these things are when you look at that, there's a massive meningomyelocele. Sometimes they're covered with thin film of membrane, and sometimes it has a good skin cover, like in that upper right picture. They are just before the surgery I have prepared. So this full covered with skin. Sometimes they are ruptured. Sometimes there's just a neural plate just flush with the skin. It's called myeloschiasis. So what you should do when you see these things. So that's where the problems comes. So as most of the neonatologist and pediatrician and sometimes the VOGs, when you see them, then you should know what to do and when to do things. So skin dimple. So it's just a dimple of just the excavation of the skin only, but most likely there won't be anything underneath. So then you can do an ultrasound scan and to make sure there's no connection, and you can observe. And what thing is, you should not miss the sacral pits and sinus, which has a connection with underneath spinal cords, because within last 3 months I have seen at least 5 kids who comes with infected sinus and having spinal abscess with paraplegia. So we should avoid that. Just taking little care of that bit, because some parents comes and tell me that somebody told me that it will disappear in 2 years time. Unless it's a dimple, I don't think anything will disappear. So you need to act, because many sinuses comes with infection. So sacral pits, when there's a pit, just a pit there may or may not have a connection, but that will not cause significant the impact on the spinal cord, but you cannot differentiate it from the sinus. So then you have to be very careful. So you have to do a MRI at the earliest possible 3 months of age, because let it grow a child little bit, then you can see the anatomy properly, and then better do a MRI scan. And then if it is a sinus, definitely it has a connection. So it needs neurosurgical referral and early surgery to prevent the infection. And if it is a leaking meningocele, you need to refer urgently. At least I should operate that patient within 72 hours. And meningocele with exposed neural plates, that's again an emergency. You have to do early surgery. But when there's a meningocele with normal skin cover, what I usually do is I wait a little bit, let the child to grow as soon as, birth within 24 hours. I mean, they are very tired of the delivery. So then we have to wait a while to grow, and then we can tackle with that later on. So these are the basic plans. And when it's a meningomyelocele repair, I usually do within 72 hours to prevent infection. And if there's a delayed repair, then there's associated meningitis, ventriculitis, a lot of morbidity and mortality associated with that. And then, and sometimes along with the meningocele, then these children can have the associated hydrocephalus. This is another problem with most of the neurologists all over. They are calling me and asking when to do the shunt. But most of them are very premature kids, and they don't have enough weight me to put a shunt. So then appropriate timing is very important before the shunt. So if you can do it early, so it will help the brain growth, but you have to appropriately plan shunt. This is a picture of the meningocele repair. If you can remember the embryology, you have to do what the embryology couldn't do during the child development in the uterus. Then you have to do the rest of the thing which the embryological evolution could not complete. So you have to get the spine neural plate and make it into a neural tube, and then put it inside the dura, and you have to close, and you have to get the good skin cover. So these anatomical layers has to be repaired. So these are the things you should do in early management of the spinal dysraphism or meningomyelocele.
Thank you, Nirukshan. So within that first few days, the 72 hours, in order to avoid infection, anything particular that you would want to tell us about, how to cover and, what particular things to avoid during that time?
Well, it's a matter of when it's, especially when it's leaking, when the meningocele is leaking, then direct communication is there. So in that case, I would prefer, because no point of putting wet gauze. If it is dry, of course, with the membrane, then you have to keep it little wet. But when it's leaking, it's already wet. So what I would say is put some Vaseline gauze on top of that and keep it covered with dry gauze. So then it will anyway get wet with the CSF. And very frequently you have to remove the dressings. And if it is dry, covered with thin film of membrane, then you have to keep it wet. So then you have to put again the Vaseline gauze and keep it covered. And try to nurse these babies prone position to prevent contamination. So then it will sort of minimize the infection rates. And if it has a good skin cover, you don't need to worry about it. Just you can nurse whatever the position, and you are not bothered much.
Thank you. So actually, the surgery was performed on day 7. So we just heard that it's ideal if you do it within the first 72 hours. So subsequently, the pediatrician and the neurosurgeon followed up this baby, and OFC monitoring was done because, as you quite rightly said, for monitoring of the head size, and they detected that there was development of hydrocephalus and a VP shunt was inserted. But I suppose, Dr. Jayatri, you would think differently, right? What would you think about the role of intervention? So far at this point, there was no specific intervention planned out for this baby.
Yeah. How early should the early interventions be, isn't it? So from the story that we can find, this is a spectrum. We really don't know whether if this child is lucky, he has had fairly early surgery and then found out there's hydrocephalus, but this case was probably not referred for rehabilitation. So there's this risk factors for cerebral palsy are there. So it could be a spectrum. Some kids might be severely affected, some kids might be not. So I should say, if there's a meningomyelocele from very early as possible, they should be referred for interventions early, so that we can provide early interventions to maximally support the brain development. So that is what I would suggest.
So actually, the initial process for habilitation was commenced at 8 months of age, and by which time he was actually able to sit with support, but there was no line to sitting or rolling over at that point. And also we noted that in the history, this was the first time that there was a referral made to the nephrology team. So maybe I can ask Dr. Vindhya Gunasekara, what's your opinion about the ideal timing, and what do you think would be the important aspects to monitor in the early phase?
Good afternoon. Yeah. So all meningomyelocele we have to consider as having involvement of the bladder. Because only 5% of children with meningomyelocele do achieve any volitional control eventually. And some of them, although not common, some of them can have significant bladder involvement even at birth. So answer to the first question is that we have to, that the child has to be evaluated at birth by whoever the clinician caring at that time. As for the subsequent monitoring, before talking about the subsequent monitoring, let's see the normal function of the bladder in an otherwise normal child and the neurologically affected child. Can I have the next slide? Yeah, so most of us do have 2 kidneys and 2 ureters which drain the urine produced in the kidneys into a sac-like structure called bladder, which is covered with the muscle called detrusor muscle. And the urine in the bladder is drained out via a small channel called urethra. And there are sphincters surrounding the urethra, which allows the opening and closing of the urethra. So basically, the micturition cycle has 2 phases, the filling phase as well as the voiding phase. And the functions of these phases are governed by the opposing actions of sympathetic as well as parasympathetic nerves, and also voluntary control of the sphincter muscles, which are innervated by somatic nerves. So during the filling phase, there is predominant sympathetic activity which keeps the detrusor muscle, the bladder muscle, relaxed. And at the same time, the sphincters remain closed, constricted, so the urethra is closed. And as the bladder fills up and reaches the maximum capacity, the sympathetic activity is abated and there is predominant parasympathetic activity or uninhibited parasympathetic activity which makes the detrusor muscle contract. So the somatic innervation makes sphincters relax, so the urethra opens and allow free passage of urine during voiding. So throughout the micturition cycle, the bladder is kept as a low pressure reservoir. So when there are spinal lesions, especially involving the lumbosacral area, some or all of these actions can get affected. So when there's a neurogenic bladder, what we usually see is either overactivity or underactivity of detrusor or sphincters. So if there's pure detrusor overactivity, child will have persistent dribbling and incontinence. And if there's detrusor underactivity, the bladder contractions affected, so the bladder will be distended, there will be retention of urine, and child will get overflow incontinence. And if the sphincter is underactive, the urethra will be kept open, there will be persistent dribbling. And if the sphincter is overactive, so the urethra remains closed, and there will be residual urine and retention of urine. And the most dangerous type is the detrusor hyperactivity against a closed urethra, so which is called detrusor sphincter dyssynergia. So it creates a high intravesical pressure, so the bladder wall get damaged, trabeculated, and the urine will be retained. So in the last two types, there will not be incontinence, but there will be urine retention with high pressures. And in reality, what we see is actually a combination of most of these bladder dynamics. And they do change with age according to the changing nature of the spinal lesions. And like most of the time, most of these underactive sphincters eventually become hyperactive with age. So if intervention is delayed, the bladder wall get damaged, get trabeculated, and then it get thickened, blood trabeculated, and there is rising pressures, and it will give this typical Christmas tree pattern, elongated trabeculated bladder. And then the urine, instead of going down, will go up into the ureters and the pelvic-calyceal system of the kidneys and damage the kidneys. And with subsequently, the damaged bladder muscle can undergo fibrosis, get stiff and thick, and then it will be like low capacity, high pressure bladder. So, there is individual variation like when these things do happen, but according to the literature, more than 50% of children have damage to the detrusor muscle, problems of recurrent UTI, upper tract dilatation, and UTI by they are like 3 years of age. So the goals of management includes prevention of UTI, prevention of incontinence, and prevention of bladder and kidney damage. The good news is that with timely and appropriate intervention, we can prevent the damage to the kidney and the bladder in 95% of cases. For to achieve that, when we notice that there is evidence of bladder hyperactivity, we should start bladder relaxation. With commonly used drug is the anticholinergic. We have to use in optimum doses. And when there's retaining, the CIC has to be started. And the bowel management also should go hand in hand with that. So surgical intervention will be left for those difficult, complex cases. And can I have the next slide there? Yes. So how to monitor? Actually, what matters is the changing of the bladder functions. The child who has an empty bladder with persistent dribbling is much, much safer than who is dry, who has no incontinence, but has a distended bladder. So we have to pay more attention to the changing nature of the voiding. So this can be done by maintaining a frequency diary. So if there is a spacing out, the interval between two wetting episodes are getting delayed, then maybe the sphincters are getting hyperactive and the bladder becoming a high pressure bladder. And at each visit, the bladder has to be palpated to see whether there is palpable bladder and get a good history to see whether there are recurrent UTI, which go usually unnoticed. May have taken treatment from general practitioners for febrile illnesses, and periodic ultrasound assessments to see bladder changes, upper tract dilatation, any residual urine. And also the bowel management also should go hand in hand with that. And then the invasive and the more advanced urodynamic testings are, they are preserved for those with complex and complicated cases.
Thank you, Vindya. Yeah, so thank you for that, detailed outline. Can I move back again to Dr. Nirukshan Jayavira to ask Nirukshan, what further, now the VP shunting was performed in this patient, what further neurosurgical interventions are required, and also when do you think we need to do further imaging in this patient?
So can you move on to the next slide, please? So now, so these are the problems that we face with these kids. So the hydrocephalus, syringomyelia, retethering of cord, and cherry 2 malformation and shunt block. So these are the complaints. So obviously we have to monitor for these things. Can you go back to the previous slides, please? Yeah. So then for long-term neurological follow-up, so even though at birth you might not have these kids with the hydrocephalus, so then we have to monitor for hydrocephalus. For that you don't need to do the CT scans, you can do the OFC monitoring, and then the regular ultrasound scan if they're suggestive of ventricular enlargement. Then I mean clinically may not have some features of raised ICP, because anterior frontals may be lax and maybe it's depressed, but the ventricles may be large because sometimes associated cortical atrophy. So then ultrasound regularly you have to monitor and see whether the ventricular diameters are getting bigger. So the ultrasound and OFC monitoring is very important. And if you don't do a shunt at birth or with the earliest, then what I would do is anyway I will plan for a 3 months MRI scan, brain and spine, because spine to see whether there's any evidence of cord tethering, and then 3 months the brain with is any abnormalities. So then depending on that can plan for a shunt. Then usually MRI lumbosacral spine. The MRI lumbosacral spine I do is usually when at the edge of the wall. If I haven't done the initial the meningocele repair, usually at the edge of the walking edge. So that is where the complication most of the time started, because then the cord is tethered, it will not rise up with the growing child. So then there's a pressure on the spinal cord, and you can have this spinal cord damage like syringomyelia. So then later we can do the 12 to 18 months of MRI scan, and then if there's tethering, then plan for a untethering of cord early.
Okay, so I think the baby had the MRI around 8 months, and then he did show evidence of tethering and did undergo untethering, and this is what the MRI showed at 14 months. So maybe now I can actually move on to Dr. Nirmal Marasinghe to ask about what should we do to protect the spine. What is your guidance to us regarding early measures that we should do to preserve spinal function and good spinal health?
Yeah, when it comes to so the spinal cord is different. What I'm talking about, the spine or the vertebral column. So we know that about 10% of patients with meningomyelocele and spinal dysraphism ultimately develop some sort of spinal deformity. So in this particular patient, of course, the initial X-rays up to 2 years, right?
Yeah.
2 years didn't show any form of deformity, but then we need to keep surveillance on them to see where, till they achieve bone maturity, there's a possibility of them developing some sort of spinal deformity. Commonly kyphosis at the meningomyelocele site, because the posterior elements are weaker, but they can get develop scoliosis as well. So clinically, of course, like you don't have to do serial X-rays as such, but you can keep an eye on them to see whether they are developing as deformity. But if at the earliest sign that you see that there's a deformity, of course, you need to get X-rays and have a look at it. Then whether what we can do about it actually depends entirely on the growth of the patient, because it's a race between growth and fusion what we can do. Because if you go and do a surgery and fuse the spine, of course, then the trunk will not grow. So it's not a single procedure as such. So depending on the patient's age and the time of their presentation of the deformity, we might have to refer to different procedures and things to do.
So a lot of careful monitoring.
Yeah, in this case, yes.
So can I move back to Dr. Jayatri to ask about what were your rehabilitation goals, and what did you actually plan to do on this patient?
Yeah, this word habilitation and rehabilitation, I myself always go back to rehabilitation. But why habilitation and rehabilitation? The two words is rehabilitation is when you are grown, you have learned to walk, and then something happens and you suddenly lose that ability and you relearn. That is rehabilitation. And when it is a little, infant, they just have not learned any skills. Therefore, it's habilitation. Even I forgot it, and Jitangi pointed it out that I have put rehabilitation every place. But actually, for children, it's habilitation, newly learning everything. So, at this current level of function, the child is now it is at about 2 years of age. This is how he ambulates, move from one place to the other. He has good sitting balance, centered play. That is, when he sits, he has very good sitting balance and can turn around. And this is how he manages to crawl on the floor. So if you look carefully, he moves right hip. He takes it forward almost, he advances with that right lower limb, and the other one he drags behind. So if you remember your anatomy, so the hip flexors are L1 and L2. So as well explained, the lesions of the spinal cord can be asymmetrical, and 1 or 2 level upper or lower on the two sides. It can be very asymmetrical. So on this child also that is the case. So can I go to the other slide and come back? So down, I mean. One more. Yes. So if you look at this slide, so ambulation, the method of ambulation in a spinal cord involvement in meningomalocele will depend on which level it is affected and whether it is symmetrical or asymmetrical. So it is usually divided into these 3 levels. Upper thoracic level, mid lumbar, and lower lumbar sacral. So roughly they are divided into 3 levels. So the thoracic and upper lumbar, they might not ambulate depending on the completeness and the symmetry. So mid lumbar, they might be able to ambulate with assistive devices, and the PNOs and physios will help to restore the optimum possible function. And usually the lower lumbar and sacral levels, if that's a complete involvement, they will be usually non-ambulators. So if you can we go back to that video, please? I'm sorry I'm going up and down, but if we can play that a little bit again. So I would ask Mr. Nuan Rodrigo, how would we proceed from here? So, what would be his plan for physiotherapy?
Basically, looking at the video, and this child is taking the right leg forward, actually, and he has a good upper limb strength, madam. And of course, what we can basically try is to do more quads. We have to measure the quadriceps strength, and as you can see, the left leg. Can we play the video again? So right leg is moving forward and left leg is dragging. So we have to assess, as madam said, the bilateral strength of the quadriceps, and if the quads are in active mode, we can do the strengthening exercises to that. And of course, there's an added advance, as he has a good upper limb strength. You can see that as he drag his body with the strength of the upper limbs. And what we could do more is to take him into a we'll play the video. We can make him in a high kneeling position and see whether he has a control over the pelvis and sacral area. And of course, we have to, madam, actually we have to try transferring methods also in same levels and different levels, and we should assess that also. And so, as madam said, the ultimate goal should be to make him ambulate. So we have to find out the ways that we can adaptively or actively make him to ambulate. So what we can do furthermore, we can make him stand with the standing frame and see how he's responding to the standing frame. So those are the basic things. And I should mention the core strength, back and the abdominal strength of the child. That really helps to do his ADL activities. So we should assess the core strength and address the core strength by doing core strengthening exercises that can really help him. So that would be the plan for the physiotherapy.
Yeah. Can we? Yes, sir.
Can I ask a question from Noor?
Yes, sir.
Do you use these electrical stimulation for these patients?
Yes, sir. But we have to see his sensory input first. If the sensory part is not affected, and if he's able to mention the intensities and of course if he responds accordingly, then we will proceed with the stimulation. And as I think you have referred us a lot to do the stimulation, and we have shown miraculous effects of that.
Yeah, so that's because now the latest what they say is even for neurologic injury, if you start electrical stimulation early, the chances of recovery is early. Basically, you are trying to preserve the motor in place of the muscles by continuous. So even if they don't have enough sensation, but you can start with the lowest and see if they don't burn, and they can stay.
So it's functional electrical stimulation of the countries, isn't it? So that the device goes with the child when they, we don't have that much sophisticated these things. So you can attach the device and let the child do functions. So that's the best way we can do it. So I wanted to talk about this picture. So this shows a child in an upright position. So though the physiotherapists will try their best to strengthen the muscles, in a meningomyelocele there's a limit that you can go. It's not like cerebral palsy where you can try and strengthen the muscles little further. Sometimes you can get to another level by muscle strengthening, but in meningomyelocele, unless the spinal level changes, we cannot really go beyond a certain limit. So and it really depends on what level the spinal cord is affected. So in that case, but every child has to be standard early. So part of Jitangi's question, because this child at least was presented at was referred to habilitation at 8 months. So there are kids who are presented very late, so then they lose all these functions. So why a child should stand up is, there are so many reasons. You can see the pictures in there's a face and eyes, so then they are lie flat. A normal child at about 6 months of age, if they are, they achieve up balance of, muscle balance to balance against gravity. So they see the world in a different level, and they can interact and they can play, that which gives them an input inside stimuli going into the brain. Imagine the same child lying flat. Unless the caregivers carry them upright, they don't see the world in an upright manner. So that is for a developing brain, that simple thing is very much affected. And likewise, that's one simple example. So all the other systems, there are benefits on upright position. The bowels, the bladder, the lungs, the bone health, and proper bone growth, they all depends on the proper upright position at the correct age. So if the child is not standing, we should give the devices to stand upright. And again, the piano will explain how the foot deformities will, if they are not addressed properly at the beginning, they will, my orthopedic surgeon colleagues would say how much problem they can give rise later for the child's function. So,
So I think you arrived at a very important point, the role of the orthotist, right? So can we ask Irosha to explain, what we can do with regard to use of correct appliances to improve, to achieve what Dr. Jayatri had in her mind?
Yeah, let's see what we can do for this patient as from the orthotic side. So you can see he's very active boy, just 2 years old. So whatever it is, so our ultimate goal is to make him mobility and ultimately participation in the society actively. Anyhow, the mobility will be depend on the level of the anatomical. This is spinal dysraphism is affected. So orthotic intervention, that is kind of non-conservative treatment. So orthosis is a device which we apply externally, body segment, to achieve or regain the function of the lost function. So in that case, for this child, he's just 2 years. He's now moving with the quadrinealing. So as the orthotic side, his functional loss, we can see that he doesn't have upright body position as well as ambulation with the lower limb. So in that case, first, our main orthotic goal is to make him stand with using of this kind of A4 as well as with the use of this standing frame. So when he's in this standing frame with this orthosis, you can see he's maintaining his upright body position, and eventually he learned by himself to how to hold his body in upright position, as well as it also helped to maintain his lower limb alignment into natural alignment of the lower limb, as well as it gives kind of physiological and psychological benefit, as my expertise explain. So this is the so anyhow, according to my short-term goal is first I want to make him stand, and then later on I want to make him ambulate using kind of this orthosis. It's the extension of K4 something. So it will help to make him ambulation. This is my long-term goal.
Yeah, thank you. So I think at this point, maybe we need to, now he's 2 years, we need to have a long-term goal. So maybe we can quickly ask each, expert as, what you would have in your mind as your main goals for the next 3 years. So Dr. Jayatri, what would be your next plan for the next 3 years?
what I can see from how he crawls, he on his right leg he probably has good hip flexion. I would, with the help of the orthosis, maybe an A4, he will be able to bear weight on that foot if he has some quadricep function. So the quadricep function of the quadriceps is the key determinant whether the child is going to bear weight and stand upright. So the other side, I have doubt whether he will develop that ability to bear weight on that side fully. So I'm expecting right side A4, maybe A4 on the left side. He might be able to he swing the right leg forward, might be able to ambulate. But first he will need the support of an ambulator like a walker. He might develop into upgrade. We'll be able to upgrade him into a couple of elbow crutches later. That's my expectation for him.
Okay. So, Dr. Gunasekara, do you have what would be your plan for the next 3 years?
Actually, they will need like periodic assessments. So as I told, with the changing spinal lesions, the bladder dynamics. Yeah, sorry. So they need periodic assessment because with changing spinal lesions, the bladder dynamics also do change. So they have to be periodically assessed, their voiding patterns, the changes in the images, and they should be examined at each visit. Mm-hmm. So we have to optimize the CIC regime, the medication we give and everything. And then periodically we have to assess the upper tracts, the kidneys as well, because some children, the kidney damage may not be avoidable because they may already have damaged kidneys. And even for those who have, good kidneys, there are instances, ample instances where things will go unnoticed and there'll be ongoing kidney damage.
Yeah, so from our point of view, I think we'll be, because this child is already on a VP shunt, so we'll be looking after for complications of the VP shunt insertion. And also the other important thing would be whether there are signs developing of a tethering syndrome. Although there was untethering done, there is always potential for retethering in this patient. And of course, to look after the other aspects, because there's a risk of infection in this child. So even this child may have features of cerebral palsy. So we would have a lineup of things to follow on. Do you have anything particular in mind for the next 3 years?
Yeah, as Jitangi said that the hydrocephalus shunt complications and like infection and shunt block, and then the retethering of cord causing recurrent neurology. Even though I have untethered the cords, still I might not be able to untether completely, or maybe due to scarring you can have a retethering. So those things we have to follow up.
So Dr. Tennakon, anything from your side for the next 3 years for this child?
Yeah. In fact, these children, the main issue is the level, depend on the level of the lesion. As we see in this kid, though there is some function of the hip flexion at the right, but the left, I don't see any improvement. So two things. One is with the child grows, the child weight also come, and then when they mature, they can't withstand whatever the existing muscle power. So we have to give a realistic goals in future. In the long run, because these parents sometimes they get unrealistic expectations. Since the child, the brain function is quite normal in most of time in meningomyelocele. So I usually, in terms of long-term orthopedic management, if there is no abductor function, I'm not going to do anything for the hips, because hips going to be out, and then the better to have a paralytic hip dislocation rather than the stiff hip by doing the surgeries, because that hamper the walking abilities. So the other thing is the knee contractures and the foot and equinus deformity. So when this child looks like have the all L5S1, even 3-4 is affected, So probably is good choice is hip knee orthosis, and then them to get some mobility. But I want the parents that going to be the lifelong braces, because we can't say that without bracing he won't be mobilized. So that has to be suppressed, because these parents are very mindful, and then even the slightest change of the power of the muscle, they blame us. When we do the releases, they know that there is a change, they don't do certain activities. So the selection of for the surgery in orthopedic point of view, I'm very careful, and then that has to be dealt with good communication with the parents.
Okay, thank you. So there are many other aspects actually which will have to come in, particularly the social support to the parents, the cognitive, and of course the bowel management as well. So let me just move on to a second case which we selected just to cover few aspects of a different aspect of the same spectrum. So here we mainly try to discuss the renal and the orthopedic intervention. So this child is 10 years, so this is of course not very well managed, so lots of complications. This child also had a lumbosacral meningomyelocele, and of course had surgery within the first 3 days of life, but then subsequently the habilitation had not actually taken place. So didn't have any hydrocephalus evolving, and the initial renal evaluations were normal. But the patient had dribbling since birth and also had recurrent UTIs, but unfortunately did not have regular nephrology follow-up. So subsequently, several orthopedic complications were also there. So let me move on to Dr. Vindhya Gunasekara to ask about, what aspects that you saw in this particular patient when you saw her subsequently.
Yeah. Actually, when this child came to us at 4 years, she had already damaged bladder and the upper tracts. But if we look at her history, she had normal kidneys and there had been no hydronephrosis or hydroureate at birth. And then at 2 years, the scan showed some hydronephrosis. And when she came, there was full-blown hydronephrosis, the bladder wall thickening, and there was residual urine, and the kidneys also looked damaged. So we started CIC at the age of 4 years, and the anticholinergics were started to relax the bladder. So, and she had severe constipation, so aggressive bowel management regime was also started at the same time. Fortunately, she did not have UTI later, and she had like minimal wetting and soiling, and she had been doing the CIC also regularly. But her creatinine when she came was high, 105 was high for the age, and it slowly increased over the next 6 years, and we saw a rapid rise during the last 10 months. So then we evaluated why this happened, So it is quite obvious that she was quite late to start the bladder management. So by the time the bladder management has started, she had been with the high pressure bladder for a while, most probably, which has damaged the upper tracts, and she had recurrent UTI. That's why the creatinine had gone up. So then the question comes, why, despite intervention, why the creatinine still progressed to increase? There can be many reasons. That's why these children need that regular follow-up. So it may be because the CIC she was doing may not be adequate, the method may not be correct, and the anticholinergics may not be in the optimum doses, and her bladder may not be relaxed enough, so it may be still a high pressure bladder. And also one important thing is that once the kidneys are damaged, the slow sclerosis of the kidney tissues may not be prevented, and they eventually, have like progressive damage, and which becomes more evident as they grow older. And in this particular child, why the creatinine rapidly rised is most probably because of the changing bladder dynamics. And this can be because the bladder is already damaged, so it may be fibrosed and all. And also it may be due to the changing spinal lesions causing the bladder dynamics to change. So at this point, this child has to be properly evaluated, including MRI spine at this point.
Is there a role for bowel management at this point?
Of course. I mean, when this child came at 4 years, she was having severe constipation. unfortunately, this soiling and incontinence is considered as a norm for children with meningomyelocele several years ago, but now, of course, most children are referred for intervention. So the goals of the bowel management includes one thing is to regularize the motions. I mean, you can't just to avoid soiling and also to avoid stool impaction. So these are the three important goals. And most of these children need like large doses of, stool softeners and even bowel stimulants like Dalcolax, even enemas, and some children need regular bowel washes to keep them, prevent soiling and constipation. So with that, there should be lifestyle modifications, including the diet and the correcting toilet posture, etc. And some children even may need surgical intervention as well.
Thank you. So just to give a glimpse of what she is able to do, she's now 10 years. She's able to sit for indefinite times and able to come to the sitting position from lying position, but she needs a force to stand. So she has no free walking. She mobilizes herself using a wheelchair. But she has been going to school and she's attending normal stream school. She has sat for the scholarship examination as well. So these are some of the things that she has had in the past, and this is how she is. So she's basically being mobilized on a wheelchair, and there is some home modification done to support her. So maybe I can ask the Miss Hirosha about the role of orthosis, because right now she's on the wheelchair, a very high chance of having spinal deformities which has not been evaluated. What could you recommend?
Yeah, at a glance, when we see that clinical picture of that patient, so you can see she's been wheelchair bounded for a long time, and you can see that wheelchair also inappropriate wheelchair. Eventually, it may cause some deformity to the spine as well as the lower limbs also. So my orthotic objective is to get the normal alignment of this spine as well as the lower limb. Because of that too much hip width at the wheelchair may cause that scoliosis at the spine. So in that case, I can provide this kind of braces for this patient to get the normal alignment of the spine. So you can see the outcome once we make the spinal braces for this kind of patients. So next slide. So when we saw that picture of that girl was in a wheelchair, so you saw that the gravity caused that her foot to pointed downward. Eventually, it has been led into a equinovarus foot deformity. Maybe it's a flexible or maybe it's a rigid deformity, as well as that muscle imbalance also may cause kind of knee deformity as seen in this picture, like knee varus valgus or hyperextension during weight bearing. So my goal is to realign this knee also with this kind of K4 braces. Next slide, please. So when come to the foot, it also in a deformity manner, the equinovarus. So we also can treat that patient to get that normal alignment of that foot with intervention of this kind of ankle foot orthosis braces. So this is one of the example we had in our clinic, Sri Lanka School of Prosthetics and Orthotics. He was a boy with meningomyelocele at the lumbar region, and the success case we had. So if we can play the video, the boy is walking. So you can see that he's having the Trendelenburg gait when he's achieving, and also he's mainly having the calcaneal gait because of muscle imbalance. He's having power of the dorsiflexors, and also he lost his plantar flexors power. So in that case, we have provided ankle foot orthosis to promote the plantar flexion action for this patient. So you can see the he's walking outside with using this kind of A4. That's about the ankle when he's having that deformity. So when it comes to the spina bifida, this kind of pathology may cause sensory disturbance also for patients. So in that, eventually when they're walking, they may have kind of pressure sores or pressure ulcers, as seen in the picture. So we are doing kind of offloading devices also to promote the healing and to get the healing for the wound. And we do the follow-up plan also for the modification, as well as this patient eventually will lead to a kind of varus deformity, kind of this in the picture. And for that also we are providing kind of a ankle foot orthosis, depend with the severity of the deformity. The prescription criteria also will be depend. And you can see the kind of orthosis we are providing in our clinic, starting from flexible, jointed, ground reaction E4. Those are depend with the functional ability and functional assess of this patient.
Okay, so thank you very much for all that information. And as you quite rightly explained, there are lots of deformities in this patient. So can I move on to Dr. Dimuthu Tennakon to explain to us the important aspects of orthopedic management and the key things that we should look after?
Yeah. I'll just elaborate. The genu valgus is that is created by the poor abductors. Because of the abductor weakness, have a lot of stress on the knee, and it automatically go to the external rotation and the valgus deformity of the knee, as well as knee ankle valgus and subtalar subtalar deformity, the plano valgus deformity. So if you can give support to the hip up to the hip level, most of these subsequent deformity can be prevented. So that now in literature says that if you apply not the A for the hip knee orthosis, so that to support that, then the alignment will maintain. So that is one thing I just want to mention.
Yes, we try to provide, but patient
not
was not willing to have that much
because
higher level.
that is a secondary deformities due to the proximal weakness. The main now for your question, so in long term especially, so it mainly depends on the anatomy level. So I don't touch the hips unless the abductors are good. So at least grade 2 or more power has to be there in the abductors, because it's going to be a failed surgery. Whatever you do, you put in the hips in, it won't stay. It will come out. So that created another contraction. Contractured hip has a more difficulties in ambulation. So we might as well leave it alone rather than doing the surgery and putting the hips in. So that won't even increase the number of, reduce the number of bracing, or it's increase the range of motion, whether it is in the hips are enlocated. So the one thing is, only indication what I do for the hips are the unilateral dislocation with a good abduction power. Then of course it is better to do a surgery, because unilateral dislocation causes a leg length discrepancy and then find difficult to walk. That is my protocol for the hips. Knees, of course, if they can get a contract of the knees, a flexion contracture, then of course we can do a limited releases, or we can use the growth modulation. So we put in the screw or anterior 8 plates to the growth, arrest the anterior part of the knee to arrest, and then let the posterior part of the knee to grow. That will correct the deformity with the time. So most of the time we see in meningomyelocele deformities are the foot and ankle issues, 80 to 90%. So that is because the imbalance of the muscle. So whatever asymmetrical involvement, sometimes some patients have some activity in the peroneal and some don't have. So then you can get calcaneus deformity, then equinovarus deformity, and then so on. So then the orthopedic point of view, we try to correct this deformity. So initially we can correct with the casting, but important thing, as you mentioned, these foods are insensate. So it has to be carefully, meticulously apply the casting. We call it total contact casting with good padding. So otherwise we might create the ulcers and blisters. And even when we give them Air Force, we should give good stockinette to wear before you put the Air Force, because that even the Air Force can cause us blisters and ulcers. And then so you can see this picture with the serial casting, most of the deformity is corrected and these tropic ulcers were disappearing. And to sustain the whatever you achieved with the casting, you can put them on bracing. So we had to tell the parents from the beginning, these children need a lifelong bracing. There's no way other, because unless we do some fusion surgeries, but it is not advocated in meningomyelocele, because we call it pediatric Charcot foot. They don't have the sensation. Their failure rates are very, very high. Infection rates are very, very high. Non-union rates are very, very high. And they are because of the soiling, frequent soiling, they can have a wound complication. So we try to do minimum releases and sometimes tendon transfers. So this is how we do the casting, and this is a few examples of the tendon procedures. We do when there is equinus deformity, we do the open tendon Achilles lengthening. Then when there is a forefoot cavus deformity, we do the tibialis. So there is no muscle or whatever the power we can create, because that's a problem with the spine. So these kids need long-term braces even after these procedures. So that's my take-home message. and this, you can see this the child how he walks with a calcaneus gait and a calcaneovalgus gait. So these are the options we have, but try to do a non-operative management as long as possible, and then finally we have to decide on limited surgical procedure.
Okay, thank you very much, Dr. Tendukon. So actually we discussed two cases just to highlight the different aspects. I know we didn't discuss about the schooling, about the social aspect, the acceptance. There are many aspects that we need to cover, but in the interest of time, we curtailed ourselves to discuss these very important aspects. So let me invite our chair, Dr. Nirukshan, to leave you with the take-home messages.
Well, this complex spinal dysraphism, it should start from the beginning, antenatal diagnosis, and you should remember, especially VO, you should remember with antenatal diagnosis, get the other subspecialties involved in this management. Then once you do that, and then once you deliver the baby, to refer to the appropriate center as soon as possible. And then early management of meningocele or meningomyelocele, early management, appropriate timing is very important. And then from there onward, rehab plan. So you have to refer to the rehabilitation, habilitation, and nephrology, and those things should be done in a multidisciplinary center. It's very important. It's very important to get involved all this team. Now we are at LRH, we are equipped with all this multidisciplinary team. So it's comprehensive management is we just started, and it will further will develop. And then once all this initial management is done, then the regular follow-up by it in each individual, the neurosurgical part by me, and the Dimutu, the rehab part, the Dimutu with the hips, and then the Nirmal, the spine, and the Jayatri, the rehabilitation, nephrology. All these things should be monitored throughout the life. There's never ending until when this child is grown up, until the death. We have to monitor various things. So it's a team management, team effort. And you all need to know that appropriately refer to the appropriate center.
Yeah, so that brings us to the end of the day. Let me hand over to Ms. Yasoda Hettiarachchi.
Thank you.
Thank you very much to the panel of experts for that very informative and stimulating discussion. I'm not taking the risk of saying that title again. So on that note, we are concluding today's program of the two-day conference. I would like to thank everyone for their valuable contribution and participation.
Doia baba, kirisi nara. දරුවා ඔබ සමග සිනා නොවීම, ඔබ දෙස නොබැලීම ඕටිසම් තත්ත්වයේ ලක්ෂණයක් විය හැකියි. ඕටිසම් ලදරුවියේදීම හඳුනාගතහොත් හොඳින් පාලනය කළ හැකි. නොපමා වමතන්න 1174093 SLACD සහ CDB සාමූහික මෙහෙවරක්.
If your child does not smile or make eye contact with you, it could be a sign of autism. Autism can be successfully managed if identified at an early age. Call our helpline on 0117490000, a joint effort by the SLACD and CDB.
குழந்தை உங்களை பார்க்காமை, சிரிக்காமை ஆகியன ஓட்டிசத்தின் அறிகுறியாக இருக்கலாம். ஓட்டிசத்தை சிறு வயதிலேயே இனங்கண்டு கொண்டால் அதனை கட்டுப்படுத்தலாம். தாமதியாது அலையுங்கள் 0117 490 0000. இது SLACD மற்றும் CDB இணைந்து செயற்திட்டம்.